I am going to pull up my slides right now and we'll get started. Thank you everybody for joining today. I missed yesterday's sessions in the conference, but I'm looking forward to joining a few as the week goes on. Always appreciate an opportunity to learn and to get to connect with others in the field as well, even if that connection is still virtual for all of us right now. My name is Megan Carolyn. I'm the Vice President of Research at the Institute for Child Success. Some of you might be familiar with us. We're based in Greenville, South Carolina, though we do have a national focus on our work, and I'm actually speaking to you today from my home in New Jersey. We are a research and policy organization focused on child well-being from prenatal to age 8. I'm going to talk more about why that matters for this paper and this work in particular, but really when we say child well-being, we mean nose to tail. We mean education, health, child welfare, any of the systems that help children and families thrive are in our wheelhouse. And so this session today and the supporting paper that goes along with it is really an attempt to try to knit together in a very, in a tighter way than we've done before, what goes on in these different sectors in the early childhood workforce. There's early care and education, there's pediatric health, there's child welfare, there's so much else going on that the systems and services that work with our families. What's the similar challenges across those workforces, and does that open the opportunity for shared solutions? We feel very strongly after this paper that yes, it does, and that really getting into these issues a little bit less siloed can be a real catalyst for change in the field. I do want to acknowledge that my colleague Amber Posey is the co-author of this paper, and we were hoping to be able to present today. She's unfortunately been out for a family emergency. This is actually going to be one of her very first conferences to present on, and so I just want to really showcase the invaluable support of my colleague on this presentation, even if she could not be with us today. So our goals just very quickly today really are to highlight some of the key findings from this paper that we released late last year, explore the challenges faced in each of the sectors of the early childhood workforce, and really highlight those commonalities, and I'm going to talk more about that in a second, and then provide systems-level opportunities to help build resilience into these workforces. And I cannot stress enough systems level. That's important to our organization, but it's essential to this conversation, because I'm going to bet that many of us would agree if we read one more article of self-care or mindfulness to treat burnout, we're going to scream, because you can't individual your way out of systemic crises. And so when we talk about the early childhood workforce and burnout and high turnover and low pay, you can give your individual providers all the tools in the world to provide self-care, but if we don't change those systems, we're just going to see this cycle repeating itself, and our providers deserve and need better. So we're really going to focus on system level, and that's going to be both policies, pretty broadly defined as government policies, kind of different levels could engage differently, and also providers. And I really want to talk about this level because many of us are in management positions, but not necessarily at the top of the food chain, right? I can't pass a congressional appropriation for more early childhood funding, but I can make changes within my workforce and my workplace to better incorporate some of the research-based principles to help this workforce thrive. Okay. How about now? Can anyone hear me?
Yes.
Yes.
Yes. Oh, okay. I don't know what just happened. It kept toggling between mute and unmute, even though I wasn't touching anything. If it happens again, I will abandon my headset and see if that fixes the issue. Sorry about that, everybody, and thanks for letting me know. So more information on the paper is available online, and I'll give this short link at the end. Now, I want to talk a little bit first about when we say the early childhood workforce, what do we mean? So as I've sort of teased a little bit here, we have a very broad focus. A lot of our work is centered on childcare and early childhood education, but then it's also health and human services as well. And really where this paper came from, and I think this is important to acknowledge, is that we realized in the research literature and in working with professionals that we know in various fields, and frankly, just among friends in my life as well, we were hearing the same frustrations from childcare providers and special ed teachers and caseworkers and pediatricians. But we were hearing them. Nobody else was sort of sitting at a place to hear all of this similar feedback from these professionals and see those linkages. And so when we talk about things like low compensation and high turnover, there wasn't a connection being made that, wait a second, this is really impacting so many of the fields that are serving children and families. What does that mean for these workforces broadly? And what does that mean for the families and children who are being served? That basically all of the providers who are involved in their lives up to age 8 are feeling some degree of burnout or high turnover. And so we really wanted to dig into this question a little bit. I will also say that our interest in this paper predates COVID. And we had been kind of tinkering around the edges with the topic for a little bit. And then when the pandemic started in spring of 2020, we were tapped in to do a survey of childcare providers in South Carolina and of pediatric healthcare providers in South Carolina. And once again, the feedback that we got about the challenges they were facing, fear of the virus, lack of access to protective supplies, sudden drop in customers in what are both essentially fee-for-service businesses, we realized that we needed to take some time to really dig into the research literature and talk about this as we move towards new normal, whatever that's going to look like in a COVID or post-COVID world, really addressing these challenges. I think we've all seen and read a lot about the crisis in the childcare sector right now related to employment. When you don't have enough providers, you don't have enough slots for children, you don't have the ability for families to go back to work in the same way that we do. And so in a very real way, this topic is getting the attention that it's needed for decades. And we're hoping that perhaps this momentum can help move us into sort of a new phase of focusing on this. So these are some of the professions that we're talking about today. Two things I want to note. First of all, there's a lot of research on educators and on pediatric medical providers, especially doctors. There's a little bit less on all of these other providers. We're going to sort of pick and choose what is available to talk about, but we believe that the findings broadly are applicable across all of these populations, as we'll talk about. But I just wanted to mention that there's not the same amount of research for all of these fields, and the need for more research is something that we would identify as well. I also want to mention that this presentation doesn't really talk about birthing professionals, OBGYNs, doulas, other family support workers, prenatal home visiting programs, kind of looks at just home visiting more broadly. And so that's something we'd like to get into in the future, but there was sort of a line of demarcation we had to make to keep this manageable for this paper. So I would love at this point, Yvonne or Chris, if you could pull up the poll. I'd love to know a little bit more about who is in our virtual room today. And so when that poll comes up, if you can just indicate which of these roles best identifies, how you would have introduced yourself if we were in person today. Oh, I have to take it myself. Hold on. And so it's just helpful to sort of get a sense of who's here. Also acknowledging that many of us wear multiple hats. And I'm also, a parent, I am an aunt. We care about these systems in a lot of different ways, right? Not just in terms of our role in the field directly, but also in making sure that these work for the families that, we care about in our communities. I've not actually done a poll before. Does it pop up the results at the end?
Let's see. Jonathan, may I show the results of this poll? Or Chris?
And just to note that there's no other option on the poll itself, so feel free to just pop into the chat box how you might identify yourself other than the options that are here.
Okay, so I'm going to say right now we have early childcare education, childcare providers at 70%.
Okay, good to know. Thank you. So the vast majority that are in the room are providers today, child care providers, early childhood education providers. Great. Thanks, everybody, for chiming in the chat as well. Great. A couple of child care health consultants, TA providers, great, CCR&Rs. Excellent. So what I'm going to do is I'm going to dive into this with the presentation that I have prepared. At the end of the session, I'd like to do sort of 2 rounds of Q&A. One will be to open up the conversation for a little bit to get feedback from you all. This is a paper that's already been published, but it's also a work in progress. And so if there are challenges that you've experienced firsthand in your work that we didn't find yet in the research literature, I'd love to know about those. We can go back and revisit and issue, an updated version. We really want to develop this as a resource. And then also we'll keep going with Q&A for any questions that you all have for me based on what we discussed. Okay, let's buckle in. So as I've already said, we really want to try to break out of silos with this presentation and really kind of push the field to break out of silos moving forward as well. And the one, silos, we talk about this a lot, pre-K, childcare, Head Start, early elementary. But then within that, or even beyond that, we get into pediatric health care, child welfare, child life services. We don't talk today about community-based programming, but houses of worship, libraries. These are all places that are huge touch points for children and families, especially at a young age. And so we really need to think about, you can only get out from the workforce what you put in terms of resources, support, and respect for the profession. And so really, what can we learn across these different sectors that can help us look at holistic solutions and realizing that these fields have more in common than they do apart. And sort of the pushback question that I might get from people is, you're talking about in the same conversation a child care provider with a CBA who opened a location in their home and is barely making ends meet. And you're talking about a pediatric healthcare provider, you're talking about your child's pediatrician who statistically is going to make 6 figures and, sets their own hours. And why would we talk about these providers in the same conversation? Because at the end of the day, the issues they're facing are more similar than not. Both are poorly compensated compared to their peers in the field who serve older populations. Both are overworked, underpaid, burnt out. Both are working very emotionally closely with families, often without the appropriate supports, either from employers or policy, to process some of those challenges and struggles. And both really experienced or currently experience a range of health and safety issues, including COVID, of course, but even going beyond that, just challenges that aren't always seen at the policy level. That impacts the services that families get. And if we want to know that our investments in early childhood are making a difference, we need to make sure that that workforce has what they need to thrive and survive. And so the 4 broad areas that we're going to discuss today, I've teased them out a little bit already: compensation, burnout, safety, and retention. We put retention at the end because once you've gotten through the first 3, you start to really sort of understand very intuitively why retention might be an issue. So compensation. First of all, just to level set on this, when we say compensation, we are talking about salary. We're talking about dollars and cents. But compensation is a much broader term than that. It also includes things like insurance and health benefits, time off for vacation, sick leave, family leave, and ensuring that those pay and benefits align with the difficulty of the work, of the need to have those staff members, and also cost of living, making sure that folks are able to live comfortably on what they're earning. Because what we know, as you can see in this bulleted list here, when compensation does not meet those basic needs, it impacts the mental health of the individual employee, low job satisfaction, which feeds into that retention burnout cycle, a non-existent work-life balance, a lack of qualified professionals in the field, a lack of interest in that market, and staffing shortages. When providers deal with material shortages in their own life, not being able to make ends meet or struggling for the compensation level that they really need for where they live, that impacts their ability to really focus and function on the job. And so let's put some numbers really kind of tangibly behind this conversation. So we've blocked these out, and the first is education professionals, which I now see has a sideways typo, healthcare professionals, and then psychology and social work professionals. These definitions are a little clunky, right? We're talking about the Bureau of Labor Statistics, so they might not all fit our needs here. And the goal is not to turn anybody against each other. I'm not going to sit here and say that the high school teacher making $62,870 is overpaid, right? We're all in this together, and all professionals deserve respect and compensation. But when you see that huge gap between a child care provider, a teaching assistant, a preschool teacher, and then the higher grades, you notice, wow, we really underpay comparatively the folks who work with younger kids. And then you get down to healthcare, and you see that the pediatrician is making $177,000 on average, and that's good, and they worked hard for that. But compared to their adult serving populations in medicine, they're making much less. You see the same thing again. You get into social workers who are commonly employed in the child welfare system, guidance counselors. Then the difference up to psychologists who work with the general population is, again, pretty stark. There's a lot of nuance that we're not going to be able to get into here in terms of those exact services, especially with healthcare and mental health care, inpatient versus outpatient, the intensity of that work. But when your aggregate data are showing trends like this, that people who work with young children are underpaid compared to their peers, you need to pay attention to it. A couple of things in particular to identify here is that all of the fields we're talking about today, these care work fields, are female dominated. Without getting too high up on my soapbox, many of us would contend that it's the devaluing of care work that has led to these long-term inequities across the field. We just don't value care of young children as real work in the same way that we value the care of adults and older children. It's a societal issue. Even in these female-dominated fields, there's also a gender pay gap. Particularly in medicine, where routinely, on average, male pediatricians, who are the minority in the field, make more than do female pediatricians. And then layered on top of that as well is there's a racial and ethnic wage gap as well. A white child care provider or preschool teacher does out-earn significantly. I think it's like 78 cents on the dollar, a white preschool teacher. And so we're going to talk here about, the high-level need for salary increases, but on the whole, we can't just stay there. We have to dig in deeper. Whenever you talk about a wage gap, somebody wants to, and it's fine if you're this person, somebody wants to raise their hand and say, well, there's so much that you can't capture in this, and people make different choices, and maybe the hours work better for that child care provider than they do for the high school teacher. That's very true. But when you have broad trends like this that shape it, it's important to pay attention. We also know that when you get into child care, the experience of running a large child care center versus a home-based child care center differs really significantly along some racial and ethnic lines. Women of color are much more likely to be sort of small business owners in the child care field of smaller child care centers. There's lots of pros and cons to taking on that ownership. But in particular, those are the centers that were really hammered by COVID and lockdown and not having access to support services. And so it's just sort of important to keep in mind all of these factors kind of converging at the same time. And then this leads to churn. And so we're going to talk about turnover a little bit more later, but it's also important to not just to think about both change in employer and change in industry. There's sort of two different phenomenons going here. I think what we've been hearing more about lately when we talk about childcare is the Washington Post article of, well, I can't hire any teachers now because Amazon has a warehouse and Amazon pays more. Or Whole Foods just opened up a new store, which is also Amazon now that I think about it. And, they're flexible and they offer leave and I can't compete with that. And so that's where you have folks with this change in industry going to another field that even just traditionally pays more. But we also see sort of a sub-level of this change in employer. If you talk with childcare and early childhood providers, and many of you may have had this experience, you'll hear in communities where there's a large investment in early ed in public schools, you'll hear like, well, if I get a job with the school district, with my bachelor's degree, the pay is higher, maybe you're in a union, there's health care benefits, You get the summers off, quote unquote, because I think any teacher out there knows they're not really summers off. But, when you look at that compared to a private child care center, you might have your most exciting, best teachers, they're really incentivized to move over to those school districts in a way that then creates churn among the smaller child care providers. That's a really serious consideration that we need to think about as we see this expansion in state and federally funded early care and education, is making sure that pay parity is built into these funding formulas so that you don't have teachers having to hop around every couple of years in chase of a higher salary, which they deserve. Benefits are a key part of this as well. The public sector, as compared to some of these smaller centers and certainly self-employment, is more likely to offer health insurance and other benefits. It even goes into other fields here too. When you talk about pediatric health care, it hadn't really occurred to me previously that if you're a solo practitioner, every day off that you take, whether it's because you're sick or because your child has a field trip, that's money that you're not making. It's a very different experience from working within a larger healthcare system. And so we see this situation where organizations that are sort of more top-heavy and have more bureaucracy are able to offer more benefits, salary, and flexibility than the smaller locations. And so it's like this funnel where people keep moving up to the larger employers, and that disadvantages the smaller organizations at the bottom. We're going to keep going right through the sort of 4 issues. I would say if you have a question that you're worried about forgetting, pop it into the chat and I'll take a look at it in a few minutes. But we're just going to kind of keep going and set our foundation for the conversation. So burnout, I just want to very quickly define, burnout is a thing and it's a very specific thing. A lot of us, myself included, sort of use the term in a more colloquial way lately. And that's good, right? Because now people are more aware of burnout. But it's a very specific state of physical or emotional exhaustion that also involves a reduced sense of accomplishment and loss of personal identity. And that sentence just gets worse as you read it, right? Because I've been tired. But when you think about a reduced sense of accomplishment and loss of personal identity, we don't want that for anybody in the workforce, especially anybody working closely with kids. Reduced accomplishment is not something I want from my child's preschool teacher, and it's not something I want from our pediatrician either. That would be bad enough in itself, but research is linked to a number of negative impacts, ranging from depression and substance misuse to cardiovascular disease to lower quality of care, and it can be, contagious is the term that was used in the literature. Once one person is burnt out, more people are likely to be burnt out. It's hard to know for sure exactly what starts that, right? Is it because you see that your colleague is burnt out? Do you have to take on more because they're burnt out, or is there something organizationally that's really burning people out? So these are complex questions when we talk about burnout. This is an area where we really do want to talk about COVID's impact. We don't have pre and post survey data here necessarily because there wasn't as widespread concern about burnout before the pandemic. But these statistics are not good. You don't have to be a statistician to tell that. Half of health professionals in a recent survey had symptoms for a depressive disorder. Half of child life specialists, who, if you're not aware, they sort of work alongside medical providers to work directly with children, especially kids who are maybe going in for surgery or have a chronic illness. It's really sort of a beautiful melding of some clinical knowledge. They don't administer clinical care, but clinical knowledge and sort of a social work perspective as well to really work with families to navigate the challenges of complex healthcare needs. So half of child life specialists were at moderate risk of burnout. 17% were high risk. And this, along with child welfare professionals, is a little bit ironic because these are folks who actually know a little bit about burnout and can maybe identify it in others, but not as much in themselves, right? It's harder to look inward. So then we also have that half of child welfare professionals had mild or severe levels of peritraumatic distress. 1 in 3 child care providers reported at least one material hardship, which is like a financial hardship, not able to pay their electric bill, food insecurity, et cetera. And those are linked to higher levels of emotional distress. And so we have folks who are coming in with some very heavy burnout, heavy stuff going on in their own lives, experiencing increased burnout in their workforce. Some of this even comes from the work that they do, right? These are frontline jobs, often working with families at some of the hardest moments in their life. And even with child care providers who get to know kids on a day-to-day basis, you get to know the kids and the families. And so when something terrible happens, when COVID, when the pandemic closures resulted in this huge economic contraction and mom or dad loses their job, as a child care provider, you know those families and you know that that's happening. And a lot of times we can take on some secondary stress as a result of trying to help them and the frustration of not being able to do so. And so these are jobs that need to be done and need to be done well, but also take on a lot of emotional baggage of others at the same time that the providers themselves are facing challenges in their own lives. And I just want to highlight, again, with burnout, it's a real chicken or the egg situation. Just to kind of quickly go through this example here, a lot of the literature on burnout could not identify what happened first. For example, was it that the provider, broadly defined, was depressed and that led to their burnout? Or were they feeling burnt out by their responsibilities at work and that led to clinical depression? Was the medical error caused by the burnt out nurse a result of her burnout? Or is it the start of a negative cycle, right? You make a big mistake at work, you start doubting yourself. That goes back to that sense of accomplishment that's built into the definition there. And so these are difficult issues to entangle, as we'll talk about a little bit in the solution section. What that really calls for is kind of a full court press, right? We need to think about all of the conditions that are going on in this workforce. And we can't just say, let's fix burnout. We need to think about all the things that are feeding into burnout, whether that's compensation or atmosphere or something else altogether. Safety. Safety is an interesting one because a lot of times folks sort of question why it's here. One of our reviewers on the paper actually sort of said that. They were like, well, I don't understand about, pediatricians. You don't have rowdy patients when you're a pediatrician. Well, the problem is you have rowdy families, right? You have families that feel like they're not being treated well, or families that are frustrated to be working in a failing system, whatever that system might be. Alongside these other issues of safety, you also have things like emergency protocols and drills, whether that's a school safety situation or within the child welfare field. Hospitals have their own set of protocols for this as well. And then as we saw during COVID, this really troubling lack of access to supplies that were needed, which was common in a lot of fields, but these were fields that couldn't go remote necessarily. And so just to give a few examples here, within the child welfare profession, these are folks who are working with families during very unique periods of stress and often in families' homes. And so a lot of, home visits for child welfare cases are home visits. There might be some protocols for safety to have more public visits, but the home is the standard. A quarter of social workers report being physically assaulted during their work over the course of their career, which is really just a staggering figure when you think about that. It's almost sort of accepted as a when, not if. And this number doesn't capture the higher number who reported fear or verbal abuse or threats, which is a whole other set of challenges as well here. And this is pre-COVID. In terms of pediatric health, nurses in particular take the brunt of this from patients. It is nurses more than doctors who are assaulted, harassed, or threatened. It is not, well, my 5-year-old might try to kick the doctor during getting shots, but the situation here is not generally a rebellious patient. It is a parent in the hospital room who's just gotten bad news that they can't accept for their child, or who thinks that they aren't getting the level of care that they deserve. Violence in medical settings is actually very, very common. As you can see here, the pediatric nurses identified this as an expected reality that they and their colleagues had adapted to. And in surveys, they were very clear that they felt supported by their colleagues, but not by administration in terms of actually even reporting these issues. It was often seen as like, well, nothing's going to change, so why do the paperwork? And with school safety, I want to sort of challenge some of our expectations and assumptions on this one, especially when we talk about early childhood. It's different than what the headlines look like, right? Obviously, anytime there's a shooting in a school or an act of mass violence, it is massively concerning. We can and should pay attention to that. But actually, the issue more often for schools and even in childcare settings are, one, community violence. It's not in the school itself. It's the walk to school. It's the neighborhood. And kids just live in that atmosphere, and perhaps the professionals live in that atmosphere as well. And then there's often unintentional injury, particularly with kids who are struggling with self-regulation. Again, some of the feedback that we've gotten on this is like, well, that sounds more like a high school problem. if you're dealing with an 8-year-old who is just completely unregulated and not able to control themselves and their bodies, the potential for real injury is there. I have friends in the field who have had surgery because of injuries that they've received on the job. One study found a higher rate of injury from kindergarten to grade 2. It was a study in Minnesota. And another in Pennsylvania found that special education teachers were almost 3 times more likely to be assaulted than general education teachers. And again, this is usually not coming from a place of malice from the student, but we're talking about, regulation issues. When we're talking about early childhood, we can't ignore the equity piece of this conversation as well, right? No teacher or staff member should feel unsafe or threatened on the job. But we also know that across private child care centers and even schools, certain children are more likely to receive discipline for acting out, and certain children are more likely to receive counseling or maybe, an intervention as a result of acting out. My colleague, Mary Garvey, who works on this, talks about the 3 Bs: big, black, boy. Boys, Black children, especially boys, and children who are older for their grade, maybe sort of earlier to the cutoff, or just larger for their age, are much more likely to result in a disciplinary referral, and that gets into that really difficult preschool to prison pipeline situation. Being expelled from a child care center should be a last resort, at the same time that we want to be sure that all children and professionals in the center are safe. And so acknowledging that all of these are complicated balancing acts, but nobody wants to work in a place where they don't feel safe. And then COVID came along and really just took these issues that have been simmering and just blasted them out into the open. Places that stayed open, obviously, pediatric practices that were maintaining in-person services and hospitals, child care centers. I live in a state where they were all ordered to close but had to remain open for essential workers. South Carolina, where we do a lot of our work, left the decision up to individual providers, which put a lot of providers in a really difficult situation. They're reading the CDC and NACI recommendations on precautions to take, but they can't get masks. Hand sanitizer prices are through the roof. We had one of our survey respondents tell us that she almost got into a fist fight at the grocery store because another patron in the early pandemic days thought she was buying too many strawberries when she was purchasing food for her child care center. And so suddenly, providers who are working in person are sort of thrown out into the wild. You get a mask and you're reusing it. Children's hospitals hit capacity. More recently, in the more recent waves of the COVID pandemic, but even before that, there was an interesting phenomenon where pediatric nurses were pulled off of pediatric floors and into general medicine, suddenly working with adults because of the shortages that were there. Children under the age of 5 are still not vaccine eligible. We're following that development closely, which introduces challenges if you're an immunocompromised child care provider. Weighing your risks here, it's a really difficult calculus. And just the unanticipated financial costs that went along with all of this, not just sourcing supplies that you've maybe never had to find before, but then finding that money in your budget as well. One of our providers in our survey told us that they had been saving to replace their roof, and all of that money got drained into their really COVID emergency fund to keep staff on board and to handle the supplies they needed. Systemically, we saw that different states were setting different eligibility criteria for vaccines, differentiating between teachers and child care providers, when in reality, the child care providers were more likely to still be face-to-face with kids while teachers were still remote, at least elementary school teachers. Folks shifted out of their specialties. The conflicting guidance was just a huge stressor for families, and the continued politicization of the safety precautions. We have heard from providers who have had families call their state licensing agencies because they thought that the provider was doing too much beyond what the state requires. And so obviously that just becomes a difficult situation for everybody to navigate at the same time that you're trying to keep everybody safe and keep your business running. And again here, I do want to identify that there's a lot of equity implications here. So the child care centers in closure optional states that were likely to stay open often reported that they needed to because they had essential worker families, or they knew that they were one of the few child care centers that was available in the area. These were often jobs that were, say, like a grocery worker as opposed to a healthcare provider. So we're talking about a lot of lower wage professionals who still needed to go to work and be on those front lines, and the providers felt an obligation to stay open to support that work. In terms of medical professionals, I'm really sorry to say that nurses and nurses of color bore the brunt of the early days of the COVID pandemic. Among medical providers who died of the virus, about 1/3 were nurses. They were not prioritized in the protection, and significant progress has been made since then in terms of protocols. But when we talk about how COVID impacted these sectors, it's not equal across the board, and I think it's important to stay focused on in this conversation. We're going to talk once more about a depressing topic of retention, and then we're going to get into some solutions and opportunities, because I realize that this could be a lot to sort of carry. Retention is people staying in their jobs. Turnover is the opposite, people leaving their jobs. You can see here, and this is a very broad list from the research literature, not just specific to these fields, common causes for leaving a position or a profession. We probably all identify with some of them to some degree, and sometimes some places just not a great fit. But these are really common challenges that we hear within this sector itself. The technology one is really interesting because this is something that we hear a lot in the healthcare sector, moving to electronic health record systems. But even within educational environments, it's another tool to learn. It's another assessment that we have to do. It's another, communication system with the parents. For some providers, it might sort of become, the juice is not worth the squeeze to every 3 or 4 years have to learn these new systems in a field that isn't offering them long-term security or improved compensation. And so, again, just to put some tangible figures behind this here. And so this is a mix of this is all recent literature. Some of it's COVID specific, some of it's not. By spring of 2020, so that was our first quarter of the pandemic, 1/3 of childcare providers nationally considered closing. And this is pretty well borne out in basically all the state surveys as well, too. That number jumps up to 55% among minority-owned childcare locations. Why? A couple of reasons. One, it's again, those are the more likely to be smaller, maybe home-based childcare homes who just felt that they didn't have access to some of the services and supports that larger organizations did. We also know that the economic and medical impacts of the virus hit Black and brown communities harder. And so oftentimes we were hearing from providers who were saying, well, I am sick, or my husband is sick and I can't have these kids in the house right now. And just the real, very valid concerns based on the disproportionate impacts of the virus. And so those closures were more likely among minority-owned childcare centers. It is very hard to give you an answer, if someone's wondering it right now, about how many actually did close, or how many stayed closed, or how many closed and then didn't reopen as something else. The way we collect licensing data, in each individual state and at the national level, it just can't answer that for us. What we do know is that even among child care centers that have stayed open or reopened, we heard a significant reduction in slots that were available because there haven't been enough providers to fully staff the rooms that are needed. We see we see turnover also manifesting as staff leaving organizations. And so just looking at the Head Start Program Impact Report, which is an annual data collection, 13% of Head Start staff left their position in the previous year. This is looking at last school year. And so 13% of all staff working for Head Start nationally leave in a given year. And of those, about 14% reported the reason as higher compensation elsewhere. We also, as we talked a little bit about, are just staff leaving the field in general. Two-thirds of nurses report that the pandemic made them consider leaving the field altogether. We need more nurses, point blank. We don't have enough to keep up with growth. And so the idea that 2/3 considered leaving the field is incredibly dramatic. All of these jobs that we're talking about today are not just jobs. They're professions, they're careers. And when you do these surveys, folks talk about, they use the words like passion or calling. These are folks who have invested a lot of time and energy in starting their businesses and getting their credentials. And the idea that any of them who really feel drawn to do this work, often for a larger reason than just themselves, would consider leaving is, staggering, frankly. And then the way that we also see the turnover manifesting is in a short tenure. Research literature holds that you need about 3 years in any given position to develop expert-level expertise. In the child welfare world, we're simply not seeing that. 1.8 years is the median for a child welfare caseworker. 2 to 4 years is the median for a home visitor in like a a MCV-funded home visiting type program. What usually happens with these professionals is they stay in the field and they move into supervisory positions, which is good for the field, right? We want supervisors who are good at their job and committed to it. And it's good for these individuals because that is where the financial growth is in child welfare. What winds up happening, though, is that every couple of years, you basically have a refreshing of the system. Families don't leave home visiting programs because they're tired of the program. They leave home visiting programs when their home visitor moves on to something new. There's also some complexities as to how credentialing works in these fields. Generally, when you're out of school and you need to do a certain number of supervised hours, some of these programs might be granting those supervised hours. Once you're done receiving those hours, you have a lot more flexibility in the type of positions that you can hold in the field and can sort of move on to financially greener pastures. And so that lack of time to really build that expertise that then gets passed on to a new generation of employee, it can prevent these fields from being what they can truly be. We sort of lose some impact with that. A business magazine would tell you that there's high costs to rehiring, and there are. There's high costs to having to recruit for the positions again, onboarding, background checks, payroll processing, all of that stuff. But what we here in this room probably really care about is the impact on the field and on the children and on the programs. If you have a program where you're constantly cycling through staff, that's not good for anybody. It's not good for long-term stability. It's not good for the families receiving those services. This is an age, up to age 8 where stability is incredibly important. And so any time that we can find a way to sort of stem some of that turnover, it's going to be beneficial for children and families. We're going to talk about opportunities in a moment here because I feel like ethically I can't just depress you about the state of the field without doing so. I just want to take a quick look through the questions. If anybody has like a substantive question thus far about the issues that we've raised, keeping in mind that we're about to talk about solutions, if there's any clarifications that I can provide, feel free to pop that into the chat now while I grab a drink of water, and then we'll dive on into opportunities. And keeping in mind that there's plenty more Q&A time at the end. Okay, great. So we'll just dive on in and feel free to park a question there if you suddenly remember it. Opportunities moving forward. We're going to talk about two different types of opportunities here. Policy level changes, and we're going to define that as basically government policy for the most part, but some of it is going to be cross-sector partnerships, et cetera. We're going to think about that as sort of above programs themselves, and then employer level, which can be more handled at the programmatic level, though it might need some additional assistance from others. These are the broad categories that we're talking about today. So increasing compensation, preparing for growth, identifying pipeline strategies, which is making sure that the field can continue being staffed into the future, and making data-driven decisions, which is one of my favorites. On the employer and provider level, we're going to talk a little bit about creating conditions to avoid burnout, peer support, virtual opportunities, professional development, and safety considerations. The paper goes more in depth on all of these, and so again, if there's something I don't touch on, please bring it up in the Q&A. But we're going to do a little bit of a gallop to kind of give you a menu of options here as we think through the future of the field. Now, this is a funny slide because we wrote this paper and released it in December of 2021. And at the time, every single headline in the paper was about the Build Back Better legislation. And this is not a presentation about politics, it's about policy. So all I can tell you right now is that Build Back Better its future is even less clear than it was when we wrote the paper 5 months ago. However, there are still some real changes that have come from an increased societal awareness of those issues that are worth talking about. And so just at a high level, policy making makes a difference. These are system level issues. We talk about childcare as a broken market. Childcare is really where we can see this the most. Families simply cannot pay for the quality of care that's needed. And so at a very high level, government is already involved, right? Whether that's funding or regulatory or something else. And so we need to think about other ways that government can be more meaningfully engaged. So just to put two on the radar here, the American Rescue Plan, or ARP or ARPA, as it was being covered in the news. This is not a childcare specific bill. It was sort of everything, right? Let's try to figure out all of the sectors that are really flailing in COVID and figure out some ways to prop them up. There were some particular focuses on public health and essential workers that have provided some opportunities for increased funding for pediatric mental health access, which is great, and employment within that sector. There was additional funding for Head Start, early Head Start, and childcare. Some of these provisions have already expired, like the child tax credit, which was for families themselves and provided some economic stability. But really, the rescue plan, it did a little bit in a lot of places. It wasn't a super focused effort on just young children. Throughout the pandemic, the CARES Act also was important in helping to financially prop up some of these fields as well. The Paycheck Protection Plan, the PPP, was essential, and NACI has done some great survey work on child care providers in particular, the extent to which businesses would have just closed without that to get through those really acute phases of closure early in the pandemic. At the same time, what we do know about these programs is they were not accessible to everybody across the board. Some of the feedback that we heard from child care providers was, you have to know how to do these applications to even get the PPP. A small home-based child care provider might not even know about them because they're not on a mailing list that's getting it. They might not know that they're eligible. A lot of folks were nervous because they were issued as a loan that was eventually then paid back. Generally, folks don't have to pay them back if they're used correctly. But a lot of folks, you're a small business owner and your child care center is in your home, and all of a sudden you're thinking, well, what happens if I don't use this correctly? Are they going to come after my house? And so there was a lot of concerns, and the rollout was so quick that folks weren't really all on the same page with it, which really left a lot of providers in small centers and providers of color behind, sort of compounding some of the inequities that we had seen there. We had also heard from pediatric providers that they were not being afforded opportunities that some of their senior citizen serving providers were to stabilize their practices as well. Build Back Better, again, that was sort of this suite of pre-K investment, child care investment, and paid family leave. I'm not going to get on a soapbox at all. I'm just going to say that right now it cannot pass legislatively. But there has been more coverage of these issues than in any time I've been in the field before, and I'm going to count that as a win for the field right now. We are seeing policymakers and practitioners and providers understand at a broad level that we need things like family leave, we need things like child care support. And I want us to think a little bit about how those impact the providers that we're talking about here, right? So your local child care provider, they're going to benefit if there's additional financial support for child care, but they're also going to benefit just by virtue of something like a government-provided paid family leave because their employer is not in a position to provide that. Research also shows that Medicaid expansion in most states is likely to be beneficial for child care providers because they're in that lower income tier that would suddenly be eligible. And so all of this to say that we can make policy specifically focused on these fields, and they're also impacted in a very broad way by policymaking in other fields as well. We need to make sure that policymakers do not forget about the needs of children when the next crisis or shiny thing comes along. We need to make sure these issues stay front and center. Compensation is sort of the elephant in the room. We're not going to get very far with stabilizing losses in the field if we don't focus on compensation. And this goes back to policymaking because we cannot provide increased compensation on the backs of families. Parents nationwide already spend 10% of their annual income on childcare. The definition of affordability is about 7%, so we're clearly already ahead of that. You can't just pass on, additional tuition fees to parents to try to pay workers more. The math is not going to work out. Families won't be able to afford enrolling. In the same way, we can't just charge more for health care to try to make up for those losses. Families with insurance are already spending $22,000 per year on their premiums, to say nothing of the out-of-pocket costs. And so these are not individual level issues to solve, they are system level issues. That can be a daunting thing to think about because how can we really think about these huge issues, without a massive restructuring of government or policy, right? Childcare is not going to overnight become the K-12 system with all of those structures built into it. There might be some structures we don't want anyway. And so we can start tinkering around the edges, right? One of the things that I say a lot when I do this work is low-hanging fruit is still delicious. And so let's start with the low-hanging fruit where we can find it. And so two opportunities here I just want to highlight are adjustments to existing financial streams. This is tinkering around the edges. This is bureaucratic math. Child care funding formulas can be tweaked to increase compensation that meets specific unmet needs. If you don't have enough infant care in a particular geographic area, there could be an incentive built in to encourage more of that. The status quo doesn't have to be the same year after year. Government has some smaller levers that can help to change that. In the same way with medicine, we know that when Medicaid reimbursement rates are higher, more providers participate. That's good for families who then get to avoid wait lists for care or really long trips to the doctor's office, on the bus or an hour drive. And it also allows more financial stability for providers who do participate. Participating providers are more likely to be in Medicaid when the Medicaid plan pays well for it, on par with what private insurance is paying. That's very, very wonky stuff. I do want to put on everybody's radar, and for those of you who are coming to this session from North Carolina, you're probably pretty familiar with the WAGES program. When I first read about WAGES several years ago, I honestly thought that there must have been a typo because it was clearly finding that relatively small supplements, and so bonuses really don't increase by more than like $1,500, were really helping to stem turnover in child care programs in North Carolina. And this is not random. They have a very specific structure in terms of the type of setting, the teacher credential, and how long you've been in the setting for that determines the exact payment month. But these small but predictable supplements were really successful at keeping providers in child care and early education settings. And there's several years of data now. This is not a fluke. And then I read a recent study that in Virginia, they've been using preschool development grant funds to do something pretty similar in terms of, again, a structured wage supplementation strategy. Again, it doesn't go beyond $1,500 a year. That increased retention, especially at private child care centers, which were largely like community-based nonprofit child care centers, as opposed to schools. And it was particularly beneficial for assistant teachers who we know are paid less than lead teachers in a classroom. And so really finding that those who were least compensated were more likely to stay with that bonus. I would expect that as more and more communities have used some of these federal funds for wage supplementation and essential worker, emergency pay, we're going to see more evidence like this. The one thing I want to caution with wage supplementation is that it's necessary but not sufficient. It's a great strategy for sort of stemming bleeding short term, and providers take very seriously the value of it, not even the financial value, the recognition of their hard work and appreciation for it. But long term, a $1,500 a year bonus is not going to be enough to change the field. We've also heard from child care providers that they're concerned about what a salary increase could mean if it was small, by which I mean they're concerned that they could lose eligibility for certain public benefits they currently utilize, like Medicaid for their children or SNAP for food security. And so that's really where child care providers are financially, are sort of right on the bubble of eligibility for those programs. And there's a concern that something like a $3,000 or $4,000 a year raise could disqualify them from those programs, but that it wouldn't be enough to sort of offset that loss. There are some policy options that, if you want to talk more about, feel free to reach out to me afterwards to sort of offset some of that. But the solution is not as simple as just writing a small check every year. We really need to think about very strategic restructuring. One of the things that Build Back Better did is it started introducing this term, true cost of care. Generally, governments set their child care reimbursement structures based on a market survey. What are other people paying for childcare? We're going to pay 75% of that as the contracted rate. But that just builds into the idea that, well, we've never been able to pay our teachers as much as they deserve, and kind of fosters that inequity moving forward. A true cost of care methodology, which Build Back Better was going to require among those receiving the funds, it estimates true cost of care. It takes a much harder look at what high quality infant, toddler, and preschool care really costs and would set reimbursement rates at that level. Even though Build Back Better has not passed, there's been a changing tone in the childcare conversation, and we're seeing more communities going out and doing these studies, even though they're not legally required to right now by their funding mechanisms. So I think that there's hope on the horizon, but these are huge issues, and it's going to be extremely expensive to get salaries where they need to be. So it's going to have to be all hands on deck. That's the big one. Our other topics will sort of move more quickly now. We need to prepare for growth. On average, the Bureau of Labor Statistics is projecting that all jobs in the aggregate are going to increase. The total number of jobs is going to increase by 8% from 2020 to 2030, so over a 10-year period. The fields that we're talking about today are going to increase by significantly more than that. And so if the U.S. average across all jobs is 8%, social work, for example, is projected to increase by 12%. Early care and education, Head Start, child care, early elementary, 18%. And so it's not just that the economy is going to continue growing, it's that growth in these jobs is going to outpace other sectors. How do we do this in a way that is responsible for those workers entering the field, well compensated, well respected, and also maintains enough professionals to take those jobs? We need to start looking into higher ed and thinking about what those pipeline situations are. How do we then keep folks in those fields, right? It's great if you have somebody come into early care and education, but if after 3 years they can't afford to stay in the field, we're just going to be, trying to backfill instead of moving forward. These estimates were made before COVID. COVID has absolutely impacted these figures. We've seen more attrition in these fields, professionals that are leaving. So again, now we need to backfill before we can even build. And it's also increased the demand on services. In particular here, I want to think about medical health care and mental health care. The New York Times just ran a huge headline last week about the mental health crisis for teens and adolescents. I work with the South Carolina American Academy of Pediatrics chapter on some of these issues as well. Kids are really struggling with a variety of issues as a result of the pandemic. There have never been enough providers to really fill all the slots that were needed there, which I'll show you in a minute. And now we have doctors talking about sort of mild PTSD that we're all coming out of this with for children who have lost a loved one during this time and really didn't have the space to grieve. What do those needs look like? Medical care has been complicated during COVID. You've had people getting diagnosed with issues later, which often means more severe. We've seen a growth of diabetes cases among kids, adolescent and child diabetes cases, some of which are short-term, some of which are long. And so the medical field is going to have new demands placed on it that weren't even anticipated within these projections. And so as much as this is a moving target, we do need to try to keep ahead of the curve. Just to give some numbers here about how bad the mental health situation is for this workforce. So the U.S. averages 9.75 child psychiatrists per 100,000 patients. So that looks at, the age of the patients, not counting any adults in there. 70% of American counties have no child psychiatrist at all. And we're talking about places where a county can be quite large, right? Where I live, the next county is only 20 minutes to the border. But when you get into other parts of the country, we're talking about, there's no child psychiatrist within several hours. And then among these child psychiatrists, even fewer have expertise in infant and toddler mental health, which is a thing. It's a solid foundation for healthy growth into the future. And by overlooking it, we sort of miss opportunities for healthy development. All of this is happening as the American Academy of Child and Adolescent Psychiatry recommends 47 psychiatrists for every 100,000 patients. So we're like 4 times below where we should be on this. And that's our estimates today. That's not taking into account all the growth that's coming in the field. And so I just want to sort of convey the extent to which pipeline is going to be a huge conversation moving forward. This is the part in the paper where we don't go too in-depth because the pipeline strategies in each of these fields do need to be a little bit different, right? The credentialing conversation in early care and education versus pediatric mental health, they're very different. But some of the current, the themes across all of these, it has to be all hands on deck. So the current professionals in the field, their employers, professional associations, policymakers, and higher education. And higher ed is really, really important to this conversation because if Congress said tomorrow that every early childhood teacher in the country needs a bachelor's degree, they're not going to say that, but as an example, we couldn't do that, right? We don't have enough teachers now who have a bachelor's degree to hit that number if that was their goal, if that's what they felt was appropriate. We don't have enough programs or enough financial aid to get people into those programs to train them. And so when we talk about policy making, we need to be sure that it's not just dreams, that we're providing a clear pathway to get there. And so things like apprenticeship programs, scholarship programs, loan forgiveness. Scholarship is better than loan forgiveness because with loan forgiveness, people always have that fear of, well, what if it doesn't work? I don't want to go into this field and find out 5 years later that I'm not going to meet the terms of the program. It's something that the Public Service Loan Forgiveness Program has dealt with quite a bit. Providers who are at nonprofit child care centers are eligible for that potentially, but it's been plagued by issues. That scares people away from that. So anything that can be done to reduce the cost of degrees, whether it's a CDA, an AA, a bachelor's, a master's, is hugely helpful to get more providers into the field. We also have to think about traditionally underrepresented backgrounds within the field, making sure that providers of color in childcare have opportunities beyond just, if they would like them, the small local child care center or child care home. That's what some folks want, and that's fine. But many folks feel pigeonholed into those expectations, and there isn't as much growth there. There's also a tendency to not include home-based child care providers as much in some of the quality improvement infrastructure that we have elsewhere, whether that's through, the NACI state affiliates. There are some communities that have had a lot of success inviting community-based providers into public school professional development settings without a very specific outreach to those home-based child care providers, many of whom provide care in off hours, right? They're not your traditional 9 to 5. If you need overnight child care because you're working at the hospital, you're not going to your local child care franchise. You are going to a small home-based provider in your neighborhood. How are we allowing people to access professional development to really supercharge their work when they have different needs, different linguistic needs, different financial needs, and different scheduling needs? And that's kind of the addressing barriers to entry. We need to make sure these fields are attractive, or else people do not want to be in them. And that's really the key thesis of this presentation is if we want the workforce that our workers deserve and that children deserve, we need to be ensuring that these are careers that give people opportunities and satisfaction and a good living. And also building these career ladders with meaningful growth and professional development. It means going beyond just sort of coursework that checks the boxes. It's giving real opportunities to thrive and develop skills and competencies. And then I want to highlight here just very briefly, there's an existing very robust landscape of professional associations working within these fields, and they are hugely, hugely important. Many of them were sources for the information that we used on this paper. They have been a lifeline during the pandemic times and understanding what's happening in these fields. They've been fielding these surveys. Of course, they can only collect data on folks who answer their surveys. It is a shortfall as compared to something like a census in the field. I've gotten some feedback that the child care registries, for example, as having a more universal perspective on child care providers could be a really, a robust source of information because they have access to more providers. But I do really want to identify that, these are the folks who know the trends are shifting before the rest of us do. These are the folks who are saying, I heard from this provider about this challenge, and I heard similar from somebody else. What's going on here? I would really love to see us work towards a framework where these associations, in addition to talking to their members and to policymakers, are talking more to each other to really identify some of these collective challenges and potential opportunities. And then just shifting over into the employer or program level opportunities, not individual level. It's not about self-care. We cannot just give people a yoga tutorial and some fuzzy slippers and tell them that they need to de-stress. Not only is that inefficient, I think it's frankly disrespectful to the folks who have really provided such essential care to our families and children, especially over the last 2 years. And so what we're going to talk here are things that employers can do even if they can't change heaven and earth within their policies. They might not be in a position to suddenly offer health insurance to all of their workers, but there are things that can be done in the meantime, again, to help stabilize the field. First and foremost is creating a culture where self-care and the employee is valued and respected, folks cannot feel like a cog in the machine. They cannot feel like they're easily replaceable. And fields that have a high turnover, folks do wonder, what is my future here? What does it look like? Should I go somewhere else? And it really means creating a culture where self-care is valued, where systems are in place to help allow for that care, to help support folks, and that burnout can be identified and managed. And so this is where my colleague Amber, who can't be with us today, helped to create what we call the Cycle of Burnout. And so to sort of walk you through it, and maybe you see yourself in this. I know I've seen myself in this too. A professional decides, I need to take better care of myself. I'm too stressed out. This job is getting to me. I'm going to draw some more boundaries on my time. I'm not going to say yes to so much. I'm going to decline some of these requests that stress my workload. I'm going to do that. And then their supervisor, not knowing about this whole process, or maybe they do know and don't think it's important, says like, well, geez, they're not showing up for these extra trainings anymore. They used to come in early to do X, Y, and Z. They must not be committed anymore to this work. They earn this label of not being a team player, which then sets them up to not get as much development, promotion, raises moving forward. This professional then feels unsupported because their employer is not recognizing the work that they do, and they're being passed over time and again. Again, this can be contagious, right? They can pass that on to their coworkers. Geez, I can't believe the way that they're treating us here. Results in burnout for the individual and possibly their colleagues, and it increases the need for self-care, which brings us right back to that first part where they try to introduce some self-care and it shoots them in the foot, essentially. The way that we break out of this is not the individual level telling your boss, well, I need to draw some lines here. Of course, we do have to do some of that as professionals in our own lives, but it's really building structures to prevent that need. And so fascinatingly, I was really surprised by this, honestly, in the research. There's a lot to be said for formal peer support networks and professional learning communities, to sort of use a term that I think is more common in education. And this is an interesting nugget in the Child Life Specialist report. They were most likely to turn towards their family for support when they were stressed, right? And then they were followed by child life colleagues and friends at about the same rate. We think that we can really move that number on the colleagues. And the reason that people turn to their colleagues is because your colleagues already know what you're struggling with. They might know, if they're at the same employer, some of the specific challenges, right? Oh, I can't believe the new PTO policy. It's so unfair. But even at a broader level, a child welfare caseworker at one agency is facing some of the same frustrations as a worker at another agency. Same thing with child care provision. Some of the struggles that you're dealing with in terms of behaviors with children, parent relationships, setting rates, all of these things, they're similar across settings. And so by creating formal opportunities for peer support, whether that's something like a monthly meeting or a more formal peer learning community where folks are going to be supported by a coach, they're going to maybe do some readings to work on their professional development, it creates this really robust opportunity to validate each other's experience and to share and to problem solve and to build. There's been some work done on virtual professional development for early childhood providers, and they found that when it was just teachers talking to each other in a chat room, sometimes they were too negative. They were too hard on themselves. Like, well, I'm reflecting on my practice and I didn't like what I did yesterday. And somebody might say like, oh, I'm sorry, that sounds hard, which is validating. But when they introduced coaches, those coaches could help them say, oh, that does sound frustrating. Is there something you would do differently next time? Or do you have some ideas for how you'd handle that? And so kind of scaffolding these supports to create some structure, you're really fostering these connections, the validation. There's also in any of these workforces where we're talking about children, whether it's FERPA or HIPAA or other confidentiality standards, people are talking sometimes about very sensitive materials, whether it's just, what's going on with one individual child or something like, in child welfare, sexual or physical abuse. They need outlets where they can safely talk to others without breaking confidentiality. And peer support communities are a really interesting model to potentially do that. We do also want to touch a little bit on virtual opportunities, and we're using child welfare as an example here on purpose because child welfare work generally, historically, has to be done in person. If your job is to assess whether abuse is going on in a home, that's not something you can really do very well through Zoom. It doesn't mean there are no options for it, though. And so child welfare professionals, in the pandemic did report that when they were able to do some of their work remotely, some of these might be more basic check-ins with a family that's moving on track, it reduced their stress in terms of transportation and the amount of travel time they were doing. It reduced stress for the families to some degree. They weren't having this stranger in their home. It increased engagement for some folks. Not everybody loves the virtual model, and that's what you hear with telehealth as well. Telemedicine isn't always the way to go, but there's opportunities to utilize it in some places to really meet folks where they are, physically and sort of mentally. Even moving meetings to more virtual settings has been shown to be effective. And that might be something that sort of strikes some of you in the childcare field. You cannot do childcare work through a Zoom. You need to be in person. But we have seen several credentialing agencies moving towards online trainings when that wasn't an option before. The American Academy of Pediatrics is doing a lot more online trainings as well. And so identifying where we can utilize technology to reduce some of the stressors and to improve access. Folks might be able to get a class that they never could have gotten in person by doing virtual professional development. On the other hand, though, both for providers and for families, we get very quickly into issues of technology access. Even here in my school district, we were halfway through the school year, the year that we were virtual, and half of the kids in pre-K hadn't gotten a laptop from the district yet. They'd been doing their pre-K on their parents' smartphone. A lot of families are not computer families. We use tablets, we use phones. And so making sure that families have access to the technology, the physical devices that they need, and then the larger issues of broadband access as well. I think we've all been doing a lot of virtual, conferences and that type of thing. And you see that sometimes your connection is just not reliable. And so we want to introduce virtual work as an opportunity to better tailor services to employees and to people who are being served, but it's certainly not all of the eggs in one basket. And then just to end on the notes of professional development and safety, I think we've touched on these themes pretty significantly by now. There's never been a better time to do professional development. The move to virtual has been really sort of staggering the opportunities that are available, but anytime that live professional development credits are required, which a lot of medical and educational associations do, you have to attend it in real time. Well, we have to make sure those presentations are also available in the evening and on weekends. Otherwise, people who are working from 9 to 5 are not going to be able to attend them. A child care provider might not be able to take a day off to go do some of the coursework that they want to do. So weekend and evenings, linguistic diversity, cultural sensitivity, making sure that coursework isn't just checking boxes. It's really giving professionals an opportunity to dive into the topics that they see shaping their work every day. And then just safety. I say just safety as if it's easy. It's not, but it's not really an issue that I can fix for us all here today. This is a really important place to listen to the voices on the ground, because when we talk about school safety as a society, a lot of times people think we mean our metal detectors in school shootings, but it is things like the out-of-control child or the child who brought a gun in their backpack because they found it in their dad's closet with no idea what it was, right? There's a difference in some of the intentionality when we're talking about young kids, but that doesn't change the safety implications for providers on the ground. And so making sure that safety is not just garnered by what gets headlines and what the state requires because they're just reacting to headlines, but also to really take into account the situations that providers are telling you they're experiencing. For example, the number of nurses who just accepted verbal abuse on the job is heartbreaking because they felt that there was no real protocol to do anything. It was dismissed as not important. Well, that might be true until you have somebody who now needs to be, walked out to their car by security because they don't feel safe going home on their own after what a patient said to them. So listening to perspectives on the ground, encouraging employees to express those concerns, developing protocols for what situations do come up, and giving real opportunities for training, because when it comes to a safety or security issue, adrenaline is often a factor, and so just having a printout of rules and requirements is not usually sufficient. You do need to give people a chance to sort of practice in the moment without going too far into the sort of more psychologically concerning like live drills. It's a very fine line, and this is an area where we don't have as much expertise, but if this is something that you have questions about, you can email me after and I can share some resources. At this point, with the remaining time, I would like to ask, I'm going to ask you to do it in the chat box, because I think if we all opened our microphones, it might be a bit much. 3 questions, and feel free to answer any or all of them. Are there challenges that you have experienced within the workforce that are not addressed here? Are there solutions or promising practices, things that you think might work that haven't been addressed here, that you would appreciate reading more resources about? We're going to probably issue, not an amendment, but a follow-up to this paper, digging into some more of these issues as well. And then my final question of, do higher-ups get these issues? I expect that many of you during this presentation were sort of nodding along and saying, like, yes, I've experienced that, yes, I've seen that. Do the higher-ups, whether that's program director, school superintendent, hospital management, member of Congress, do you feel that they're getting these issues to understand the need for solutions? Or do you think at this point there's still a lot of shouting into the wind? And so I would encourage you to just pop into the chat any reflections that you have on these 3 questions, whichever ones you'd like to choose, challenges that we didn't cover today, solutions that you think could merit more consideration, and the experience of whether higher-ups sort of get the issue. I'll give everybody a moment. I would also say the default on the chat is to send it to everybody. If there's anything that you would prefer we not share out, broadly, you can feel free to you can just choose to Megan Carolyn, and it'll go to me and also the hosts of the event if you don't want it to be quite as public. Okay, so good. We're getting some feedback in here. So interestingly, we're getting a little bit of the higher ups get it, and then also still seeing the child care crisis as a women's issue. You can hear my own little child care crisis in the hallway out there. My son is with my mother. I don't believe that white male politicians understand the issue. Yeah, one of the things that I wanted to identify here as well is that the folks who are in these fields are likely to be mothers. I had it written down somewhere here. 86% of early career pediatricians have young children. 60% of child care providers have children. Yeah, 60% of child care providers have a dependent child at home. 1/3 have children under age 5. And so generally, like, these are fields that are not just women dominated, but mother dominated. And we know that the pandemic disproportionately impacted women. We're not going to peel back all the layers in that onion as to how that happened, but there's some really good research out there about that. Women were the ones who took on the roles of virtual at-home schooling, who took on the role of, a COVID medical officer in the home to try to figure out, what precautions were needed. Women were more likely to step out of the workforce or reduce their time than male partners were. So yes, we are hearing that, sort of these issues are still relegated to women's issues. Vaccine mandate was an issue. Finally, higher ups offered real monetary compensation and a vacation day to get into compliance. Okay, so that was a carrot, not stick approach to vaccine mandation, was trying to get people, treat them for doing something rather than punishing. Focusing on staff mental health. This one, I work with a lot of directors. The directors get it, but they just don't have solutions. And so to me, that's sort of a call for action and more conversation around these areas, because there are, small, medium, and large opportunities here. Businesses need to better understand the lack of childcare. There aren't enough teachers in the classrooms. We will bounce back because of the resources provided now. Okay, so there's a lot going on here in terms of the ongoing not being taken seriously as professionals. So just, you all are apparently still seeing the churn that we're talking about, the idea that we sort of have to convince folks sometimes to take this seriously, to move forward on these issues. But also I heard some promise in there in terms of focusing on staff mental health, identifying the value of providers, and hopefully moving forward, just finding more ways to make these opportunities a reality. At this point, what I would like to do is just sort of move on. I'm going to put up here my contact information, the link to the paper, also the link to the survey for the conference itself, and open up for any questions that you all might have for me. And I would encourage, if you have a really specific question about, more information on something, feel free to email me and I can make that available. And if you have sort of a broader question that might be of interest to others, we would love to hear that. Yvonne, Chris, Heather, what's the preference here? Is it for folks to unmute themselves or to use the chat box?
Either one, they can unmute themselves or put it in the chat.
Great. Yeah, Terry just sent in this great comment. It's so frustrating because it seems all the world is about mental health and resilience and nurturing infant brains early, but the child care workers are not as valued as other teachers. And it's absolutely true. The Center for the Study of Child Care Employment at Berkeley is such a phenomenal resource on this. And they've painted a pretty clear line from, child care workers who are underpaid and concerned about their own food security are impacted in the classroom. The quality of care, the sensitive and responsive interactions that we know children need, it's harder and harder to do that. I mean, I have a 5-year-old and a 1-year-old. When I have a bad day, I am not as good of a parent to my kids, right? They can tell that I'm not fully there. They can tell that I'm stressed. When we've created a system where providers come in every day being made to feel like that, what does that do to the individual? And what does that do for the children? And I think it's really important to consider too, childcare subsidies or pre-K in a lot of areas are eligibility based, right? So we might be looking at lower income kids here to begin with. So these are some of the same families who are getting the child care subsidy, which is underpaying teachers, or Head Start. And they're also the same ones who are getting Medicaid, which is a phenomenal program. But what is the quality of care that the Medicaid provider is able to provide when they have to book more appointments than they can actually get to break even because Medicaid reimbursement rates are lower? These kids are in multiple systems that are not meeting the needs of the workforce. And so we can potentially see those impacts being compounded. A child welfare professional who goes in there completely stressed out and burnt out is not doing their best job in what is an extremely important decision point for a family to get a family through crisis. And so the way that we see these things sort of domino down on these very pliable, beautiful little brains, it's concerning. And I'm really grateful to everybody who has been sharing the challenges that they're experiencing and seeing. I'll go through the chat archive afterwards and maybe put together like a blog post that I can share out addressing some of these, because I think there's a lot of valuable conversation here. Sorry, I hope you guys can't hear my little one in the background, but that actually kind of seems on brand that I would have a crying kid in the background of this presentation.
We love it. We love it. Yes. So I'm going to take a moment while you're finishing up there to thank you so much, Megan, for this wonderful information. Yeah. Thank you so much for sharing this information with us today. I'd like to also thank everyone for attending today's session. We are glad to have you here. Please complete the surveys. We do have a sponsorship session coming up at 3 o'clock with the Wells Systems Foundation. And so also I'll let you know that another password will be given out during that session. But we have a winner for this session for today's prize from Lakeshore Early Learning, and it's the Tilt and Turn Liquid Sensory Windows. And our lucky winner is Megan Keenan. Megan, are you still with us? If you just say hello, and I'll send you an email for your mailing address information. Is Megan still with us? And if not, that's okay. I know she was in our session for a very long time. Wonderful. Well, thank you all. Do you have any last words for us, Megan?
I just want to thank all of you for what you do. This work is hard. This work is exhausting, and I say that as somebody who works behind my computer, each day. There are days that I have to walk away from this research. When we did our survey on COVID childcare providers, I had one person respond that they had to close down for a few weeks because their husband had died, and then they had to reopen their center. These are not normal times. This is hard work in normal times. These are not normal times. And so thank you, whether you are directing a program or on the front lines or working in policy. Just none of this is going to get done, on its own. So thank you all for rolling up your sleeves and getting in there. And if we can do anything at the Institute for Child Success to help support you in that and share resources, please don't hesitate to reach out.
Thank you again. Thank you. Thank you all for attending.
Thank you,
Enjoy the rest of your day. Thank you, Megan.
Thank you.
Bye-bye.
Bye-bye. Thank you all for your help with running the session.
Yes, thank you to all my co-hosts. Thank you.